We would like to thank BMS and KZ Pharmaceuticals for providing educational grants to support this program. Sandy Gilbert from the Cooley's Anemia Foundation for helping us to make today's program possible. Today's presenter, Dr. Sujit, Sheth, and last but certainly not least, we would like to thank you for participating in today's webinar. We recognize the importance of being an informed patient and caregiver and hope that today's webinar provides you with an improved knowledge of available treatment options for beta thalassemia. We encourage you to type any questions you may have for recording today's webinar, and we'll send you a link so that you can watch it again or share it with others. Before we get started, we have just a few quick polling type questions we would like you to respond to. We want to assure you that your responses are anonymous. Which of the following best describes you? Okay. Our second question for the day. How confident are you in having a discussion about available beta thalassemia treatment options with your healthcare provider? A, I feel comfortable having these types of discussions because I do not feel that I am well enough informed. Therefore, I tend to be more of a listener than an active participant when treatment decisions need to be made. B, I wish I was more informed about available treatment options, but it doesn't stop me from asking a lot of questions. Or C, I feel well informed about the available treatment options and am very involved in my treatment strategy decisions. Please go ahead and choose the best response. Okay, and then the third and final poll for today. How often do you participate in patient caregiver programs on beta thalassemia like today's webinar? A, this is the first time I have participated in a program like this. B, I have participated in approximately 2 to 4 of these types of programs. Or C, I have participated in greater than 4 of these types of programs. Okay, I'm going to go ahead and close the poll. At this time, I would like to introduce Craig Butler. Craig is the National Executive Director of the Cooley's Anemia Foundation. Craig could not join us in person today, so we will be playing a pre-recorded message at this time.
Good afternoon, and welcome to today's webinar on expert perspectives on novel therapeutic agents and optimal management strategies in the treatment of beta thalassemia, which will be presented by Dr. Sujit, Sheth. I'd like to mention that this webinar, which is geared toward people with thalassemia and caregivers of people with thalassemia, is part of a project which includes a series of 15 live, 1-hour accredited webinars presented by national and international beta thalassemia clinician thought leaders, conducted in partnership with hematology oncology departments in community hospitals, regional cancer and blood disorder centers, and academic centers nationwide. There will also be a 1-hour accredited online version of the program available for clinicians who are unable to participate in one of the live webinars. The recent advances in novel treatment strategies for beta thalassemia have expanded options to improve patient outcomes, and this program will help healthcare providers to stay abreast of these changes and make optimal healthcare decisions for their patients with beta thalassemia. I would like to especially thank Bristol Myers Squibb and KZ Pharmaceuticals for their support of both the clinician and patient caregiver programs. As the premier voice for thalassemia in the United States, the Cooley's Anemia Foundation is proud to be a part of this webinar. Many of you viewing this are already familiar with the foundation and our efforts to advocate on behalf of the community and to provide education and information about thalassemia to patients, families, providers, at-risk populations, government agencies, and the general public. If you would like to know more, please visit www.thalassemia.org or email info@thalassemia.org. Now it's my pleasure to introduce today's presenter, Dr. Sujit Sheth, who is the Chief of the Division of Pediatric Hematology Oncology and Professor of Clinical Pediatrics at Weill Cornell Medicine and an attending pediatrician at New York Presbyterian Phyllis and David Kamensky Children's Hospital and Weill Cornell Medical Center. He is also Vice Chair of Clinical Research in the Department of Pediatrics at Weill Cornell Medicine. Dr. Sheth also directs the New York Comprehensive Thalassemia Center and is a valued member of the Cooley's Anemia Foundation's Medical Advisory Board. Dr. Sheth.
All right. Let's hope everybody can you see my screen, everyone? Or
That's good, Dr. Sheth.
yes. Okay, great. So thank you, Craig, for that introduction, virtually, as it were. It is indeed my pleasure to make this presentation to the patients and whoever else is on the webinar. So welcome. I'm going to try and focus this in a much more practical manner and not talk too much science and too complicated methodologies and stuff like that. But I would encourage you to put in the Q&A any questions that you might have that we should save to the end, and then I will try and answer all of them as they come in. As was mentioned by Kimberly, this program is supported by educational grants from Bristol Myers Squibb and Casey. And I don't need to repeat this because this is something that all of you who are part of the Cooley's Anemia Foundation know already. It's a great organization, has been a strong advocacy voice for patients with thalassemia for a very long time, doing absolutely amazing work, both with patients, families, and providers, as well as supporting research. So I encourage all of you, if you haven't visited their website, to do so right away. These are my disclosures. I will be talking about products that are not yet FDA approved, that are in clinical trials and providing you with results from those clinical trials. And these are the learning objectives. I would like all of you to have a clear understanding of the disease and its management in 2021. Know the safety and efficacy of different iron chelators, understand patients who are good candidates and how stem cell transplantation might affect them. Also have a broad understanding of the safety, efficacy, and medical need for novel therapeutic agents to reduce transfusion burden in patients with beta thalassemia. Understand the current state of gene therapy trials, and then towards the end, talk a little bit about the importance of transition from pediatric settings to adult settings as well. So I'm not going to go into belabor a point and go into details about this structure, but this is the hemoglobin structure. It's a very complicated molecule, and there's 2 alpha globin chains and 2 beta globin chains in normal adult hemoglobin. When you have abnormalities either in the amount of globin that you make or in the type of globin that you make, then you have a hemoglobinopathy. And thalassemias are what we call quantitative disorders because you don't make normal amounts of the normal beta globin chains, and therefore you have an abnormality. And this just shows the geographic prevalence of thalassemia. It's much, much more common in originating around the Mediterranean and parts of Africa, as well as in a huge swath of Asia. And this is alpha and beta thalassemia that's shown here. The beta thalassemia belt is more in Asia and around the Mediterranean, and not so much in Africa. It's estimated that 1.5% of the world's population, which is about 90 million people, are carriers worldwide, and there are about 60,000 affected individuals who are born every single year with thalassemia. The exact prevalence in the US is not known, but it's estimated to be about 2,000. Compared to that, Italy has about 6,000 individuals. but the highest prevalence remains in Asia, particularly South Asia and Southeast Asia as well. However, it is now a worldwide disease, and as you can imagine, immigration patterns have led to it being present now in all parts of the world, albeit in small numbers. And this is just a spectrum of the disease, the clinical spectrum. You have the mild version of it, which is over here on the left-hand side of the slide, which is a mild anemia, which is either normal hemoglobin levels or just in the mild anemia range at the lower end of normal. And these are individuals who have either beta or alpha thalassemia trait, or minor, what we call. At the other end of the spectrum, on the right-hand side of the slide, is the transfusion-dependent phenotype, which is the most severe phenotype, where individuals have severe anemia and have either alpha or beta thalassemia major. And then in between is a disease of intermediate severity, which is why it's called alpha or beta thalassemia intermedia. These are individuals who are not transfusion dependent, but may have some complications related to the thalassemia itself, and occasionally may require intermittent transfusions for specific events that cause stress and a drop in the hemoglobin level. We'll focus most of the rest of this talk on beta thalassemia. Now, this is what happens in your bone marrow if you have thalassemia. You have two stages in which your red blood cells are made. The first stage is where your red cells are proliferating, and then the second stage is where they mature and they become mature red blood cells. And normally what happens is that you have, in the proliferative stage, you have an increase in the number of cells, and then the number of cells remains the same as these mature, but they start to mature and differentiate and become what we need as full-blown, fully mature red blood cells as they come out of the circulation. And hemoglobin is only produced at the time that the differentiation and maturation begins. In thalassemia, you have what we call ineffective erythropoiesis, and that means that you're not able to produce normal amounts of red blood cells at the end of it because of this imbalance between your alpha globin production and your beta globin production. So you do have a very robust proliferative phase, and so you make lots and lots of cells that are coming out from the original stem cell. But then when it comes to maturing, they don't mature normally, and so many of them tend to die off in the bone marrow itself because they're not able to mature normally. And so very few red cells come out. So if you compare this and you compare this, you see that there is markedly more proliferation in thalassemia, but the output of cells is actually much lower, and therefore the hemoglobin level is much lower as well. And that's the cause of the anemia. So essentially, thalassemia is a disorder of ineffective erythropoiesis. And this again correlates the phenotype and the genotype. And so you may have heard the term beta plus and beta 0. One normal beta globin gene means you have thalassemia minor or thalassemia trait. These are individuals with no anemia or mild anemia, as I mentioned before, not transfusion dependent, and generally quite asymptomatic. At the other end of the spectrum, the most severe is beta 0, where you're making no normal beta globin at all. And that results in a transfusion dependent state, which requires lifelong supportive care, transfusions, chelation, monitoring, etc. And then in between, you have this beta plus, or beta plus, beta 0, where you have low amounts of hemoglobin A being produced, but not absent completely. And these individuals may have a moderate anemia and may require transfusion sometimes, but not regularly. However, it is important to keep in mind that over time, many of these individuals with thalassemia intermedia may progress to becoming what we call thalassemia major. So they may progress from being non-transfusion dependent to being transfusion dependent over time. A number of different reasons for this, but it does happen as individuals get older. This is a very busy slide, and I'm not going to go into details. I'm just going to suffice it to say that right up here at the top, this is the basic problem. You don't make enough beta globin. You have an excess of alpha globin when you have beta thalassemia. You have an ineffective erythropoiesis of the bone marrow, a lot of bone changes, a lot of enlargement of the liver and spleen as a result of that. There's anemia. That anemia results in red cell transfusions being necessary, which gives rise to iron overload, which we'll talk about in more detail later. Wherein you have complications, also we'll talk about later, endocrine complications, heart disease, and liver disease. But the symptomatology is here. You're pale, you're fatigued, You can't really do a lot of exercise without getting very tired, and that impairs your quality of life. And that causes, in children, it causes poor growth and development. Maturation may not occur normally. And then for those individuals who are not regularly transfused, you may develop thrombosis, the leg ulcers, sudden cerebral infarcts in the brain, development of pulmonary hypertension, and then you may have an increased risk of developing blood clots because of the vascular disease as a result of these abnormal cells coming out of the bone marrow. The course in transfusion-dependent thalassemia is regular blood transfusions, usually every 2 to 3 to 4 weeks. A splenectomy may be recommended in special circumstances. We have moved away from doing splenectomies as a routine. Iron chelation therapy. Hematopoietic stem cell transplantation is really the only curative therapy that is available currently. But for that, as you'll see later, you need to have an appropriate donor. We now have a new drug, luspatercept, that is able to reduce the transfusion burden in a proportion of patients. So that is something that may be incorporated into the treatment regimen as well. But other than that, the usual course is continued monitoring for iron overload, iron chelation therapy, modification of iron chelation therapy, monitoring for side effects of iron chelation therapy, and then monitoring for complications of the disease itself. This is an important slide because it's very important to keep in mind that there is plenty of evidence now and guidelines that have been published, including on the Thalassemia website, where it's recommended to keep the pre-transfusion hemoglobin level in the range of 9.5 to 10.5. This means that before you get your transfusion, when they check your hemoglobin level, it should be between 9.5 and 10.5. And the reason for that is to suppress your own bone marrow, which is producing abnormal cells, to prevent these abnormal cells from coming out and suppressing the bone marrow. And that prevents the bone marrow from expanding and prevents the bone disease, as well as the enlargement of the liver and spleen. And so this is a very important concept to keep in mind. And this is something that you must advocate for yourself to say, my hemoglobin before transfusion should be in this range. There are ways to minimize the amount of transfusion you get. And one of those is splenectomy. But again, as I said, we'll talk about that later, but we don't recommend it routinely. And the other now is the use of luspatercept, which we will also talk about a little bit more later. Non-transfusion dependent patients, the treatment is mostly supportive. So you monitor for bone health, vitamin D supplementation, folic acid supplementation. If you're at risk for blood clots, then therapies to prevent the development of blood clots. Splenectomy is recommended again only if the anemia is severe and the splenomegaly is severe, so the spleen is very large and is susceptible to traumatic or spontaneous rupture. These individuals may require periodic or episodic transfusions if they develop leg ulcers, a really big spleen, or during pregnancy or surgery whenever there's a stressor. Iron chelation may be required even though these individuals are not regularly transfused, they can become iron overloaded. And so that has to be monitored and periodic treatments may be necessary. These may be intermittent, but not continuous, but they are necessary. A variety of different drugs have also been tried to try and produce fetal hemoglobin. Hemoglobin that's not normal hemoglobin A or adult hemoglobin, but fetal hemoglobin. So a variety of different drugs have been used with varying results. Some have some better results than others. But in general, many of these drugs are not good therapeutic agents for most patients with more severe thalassemia intermedia. Luspatercept is in clinical trials for non-transfusion dependent patients. And then stem cell therapy and gene therapy also we'll discuss briefly later on. Let's talk about that splenectomy. In the past, we would regularly do a splenectomy once your transfusion requirement went above 200 mLs per kilogram per year for 2 years or 3 years in a row. Many reasons for that, getting bigger, developing antibodies sometimes, or just having a very large spleen that would eat up the red blood cells prematurely and therefore result in an increasing need of regular transfusion. In non-transfusion dependent patients, because you're not making enough red cells in your marrow, you try to make more red cells in your spleen as well. And that's the reason that the spleen gets enlarged in that situation. So massive splenomegaly or a risk of rupture would necessitate taking the spleen out, but The risks of that are you're susceptible to infection because one of the things that the spleen does is it filters bacteria out of the blood. And two, it also filters some of these abnormal cells that are coming out of your bone marrow. The most abnormal cells are filtered out, but because otherwise, if they're in the circulation once your spleen is taken out, they can go and stick to the lining of the blood vessels and cause damage to those linings and cause vascular disease. And that is the basis for the development of things like pulmonary hypertension or silent cerebral strokes. The benefit, of course, is to minimize transfusions and therefore minimize iron loading as well. And these are all the complications of thalassemia. So on the left-hand side, you have complications in transfusion-dependent patients, and these are complications that are mostly related to the iron overload. You can see there's all these hormonal abnormalities, hypothyroidism, parathyroidism, hypogonadism, diabetes, osteoporosis, but it also can cause heart failure or the development of arrhythmias or irregular heartbeats, as well as liver disease, which could lead to liver failure, viral hepatitis contributing to that, as well as the development of hepatocellular carcinoma. On the right-hand side of the slide, you see complications in transfusion-independent or non-transfusion-dependent patients. And here, most of these complications are related to the blood vessel disease, silent cerebral ischemia or silent strokes, the development of pulmonary hypertension, the development of venous thrombosis and leg ulcers. Splenomegaly does occur again. The development of extramedullary hematopoietic tumors, pseudotumors. These are lumps of bone marrow tissue that comes out of the bone that can cause compression, pain, oftentimes back pain and leg pain. So those are things to definitely keep in mind and speak to your doctors about that if you have those symptomatologies. Gallstones from just the turnover of the red blood cells that are transfused. And so those are all the complications that you think about in transfusion-dependent patients and non-transfusion-dependent patients. But the one thing that occurs in both is iron overload. In transfusion-dependent patients, it's much more severe, and that's because you're putting in so many red blood cells into the circulation, and red blood cells contain hemoglobin, and hemoglobin contains iron. There's no way of taking the iron out of the red blood cell before you transfuse it because it cannot be removed from the hemoglobin molecule. So you're getting transfusions. This comes into the circulation here. It gets taken up by what I've shown here as monocyte macrophage system, but mostly that's in the spleen. The spleen is where the older cells get filtered out. And then the iron from that gets recycled to the bone marrow to be put into new red blood cells. But if you're suppressing the marrow and you're not making red blood cells, then that iron accumulates. And it goes to storage sites, such as the liver and the spleen. And it loads up there. And you can see here that, after about 100 units, your liver is pretty filled up, your spleen is pretty filled up, and iron is now depositing in other organs. So your muscles, your heart, your endocrine organs, etc., can get deposited with iron. So it's really, really important to start treatment and prevent this from happening and to get rid of that extra iron as it's coming in as well. Essentially, I'm not going to go through this in great detail, but basically to keep in mind that the toxicity of iron to a tissue depends on the level in the tissue, the sensitivity of that tissue to iron, and the amount of time for which it sits there. So the person who's at greatest risk is somebody who's at a high level of iron in the liver, where it's sat there for a number of years because the liver is susceptible. And so that can cause scarring and fibrosis there. So you don't want iron to build up. You don't want it to be there for very long. If it has built up, you want to get rid of it as quickly as possible. And that's where chelation is most important. So these are the complications that I've already mentioned. The liver, the heart, and the hormone-producing glands can be affected. And then it's really important to monitor this iron overload, to monitor the rate at which the iron is depositing based on how many transfusions you've gotten. You need to monitor how well you're doing with your chelation therapy to see whether you're able to take enough iron out and keep the levels exactly where we want them to be. And to look and see whether there's more iron in the liver or more iron in the heart. And so we do this by doing MRIs. And the MRIs are able to assess the amount of iron you have in your liver. And the normal value of your liver iron is less than 1.6. The ideal range that we like to keep your liver iron in is between 2 and 5. So not normal, a little bit above normal, but not very high either. When it comes to the cardiac T2 star, normal is more than 20 milliseconds. So again, the difference here is liver, higher numbers are worse, heart, lower numbers are worse, okay? Now, this is another very important slide that you have to really understand. This is a correlation between the serum ferritin level, which all of you know is very commonly measured as a marker of iron overload. So that's here on the x-axis. And on the y-axis, you have the liver iron concentration, which is really truly the gold standard for how much iron is in your body. And you can see here, I don't know if you can follow my arrow, but if you look at the 1,000 number on the x-axis here, you can see that somebody who has a ferritin level of 1,000 may have here a liver iron that's normal, a liver iron that's 5, a liver iron that's 10, a liver iron that's 15, that's 20, or even 30, all with the same exact serum ferritin level. So it is not an accurate way of assessing your total body iron stores. And therefore, it is really, really important to get that MRI, both of the liver and of the heart. Why both? Because here, if you look down below here on the right-hand side of the bottom, there is not a good correlation between the liver iron and the heart iron, between the LIC and the T2 star. You can see that these points are all over the place. It's not like if you have an increase in LIC, your cardiac iron goes up as well. Sometimes it remains flat, but sometimes even for individuals of a low LIC, you might have a high T2 star here, or a low T2 star, which is low is worse, low T2 star here. But the MRI is the way to go. It's non-invasive, it doesn't involve any radiation, and it's relatively easy to get. So definitely ask about that, because that is the gold standard for monitoring iron overload. There are 3 iron chelators that are available. You have deferrocyrox, which is X-Jade and Jade-Nu. You have deferriprone or Ferriprox, and you have desferol or deferoxamine. Deferoxamine has been around for a long time, since the 60s. The problem with it is that it has to be given by injection. You see this little pump here at the right-hand side of the bottom, and has to be given through that pump as a subcutaneous infusion under the skin for 8 to 10 hours, 5 to 7 nights a week. Needless to say, not comfortable, very cumbersome, sometimes painful. And therefore, compliance is not very good with this treatment. Luckily, we don't use it now as first-line therapy for everybody, because we have oral alternatives. But there is data that shows that if you were more compliant with your chelation, that you can see here, individuals who got 300 infusions or 225 infusions a year did much, much better than individuals who got fewer infusions. This is a survival plot. And you can see that if you were not compliant with your chelation, you tended not to survive well into your 20s and 30s. Deferriprone was approved in the US, at least in 2011. It is primarily used in combination, but there are some patients who use it as first line in primary therapy because they've not been tolerant to the other agents. It is effective in reducing liver iron concentration, but it may be more effective than the other chelators in removing iron from the heart. It does have some side effects. The worst one that we have to really be concerned about is agranulocytosis, where your white blood cell count drops really low, and then you're susceptible to getting infection. And then you have deferrocyrox, which is X-Jade or Jade-Nu, also available in sprinkles for little children. This is orally effective once a day, and so it should be relatively easy to do a once-a-day medication to keep your iron under control. So really, really important to keep this ongoing and be compliant with this. It does cause some liver and kidney toxicity, so that has to be monitored very carefully. It is effective in removing iron from the heart as well, and there's good long-term and short-term safety data and efficacy data as well by now. So it can be used by itself or in combination with one of the others. And this is a slide that dates back to 1994, but things have not changed. Effective chelation and your survival is perfect. Ineffective chelation and you don't survive as well. So really important to monitor the iron levels, tailor your therapy, and then take your chelation as your doctor advises you take it to make sure that you don't become iron overloaded, you don't have complications that I mentioned before. So from the chelation standpoint, compliance, 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 the most important thing. Each chelator has to be taken in a particular way. Neferoprone has to be taken twice or 3 times a day. Neferocyrox has to be taken on an empty stomach. Important to keep in mind, don't take any other medications for at least a couple of hours when you take an iron chelator because they can have some drug interactions. Also important to hold all chelation if you have a fever for at least 24 to 48 hours after the last fever has gone, because you can make an infection much worse by taking your chelator at the same time if you have an infection. And then you need specific monitoring for neferoprone, its blood counts for neutropenia, and for deferocyrox or p1iqjCOw3yw, its liver and kidney function, as I mentioned already. We'll spend a minute talking about stem cell transplantation. This is the only curative option currently available in the United States. Very important to keep in mind that you need to have an appropriate donor in order to have the best outcome. And that appropriate donor, based on the literature, is a fully matched relative. Okay, so if there is a sibling, a brother or sister, you can always ask to be tested to see whether or not that sibling is a match. And if that sibling is a match, then going to transplant is a good option. It's important also to keep in mind that your pre-transplant organ function is really important. So if you have liver dysfunction or kidney dysfunction, say because of iron or because of your chelator being given in a high dose because you have very high iron overload, then you might not do as well during transplant. And so it's really important to keep your organs in good shape, to keep those iron levels down, not have to be on high doses of chelator where toxicity might occur. Younger patients tend to do better than older patients do because, again, their organs are in better shape because they've not had iron overload for a long period of time. And then, as I mentioned, related donors do better than unrelated donors, as you can see from the numbers here in the graph. And the level of match is important as well. So 10 out of 10 is ideal, and that's what we hope for. However, results are getting better and better. Even with the unrelated matched donor transplants, results are getting better. So these are options to discuss with your hematologist or transplanter and get a full sense of what the results are from these transplants before you decide. This is a graph of survival. So without any treatment at all, individuals with beta-0, the most severe form, would die in the first 2 to 5 years from heart failure because of the severe anemia. Non-beta-0 individuals could live for longer periods of time, but with varying complications as well. Now, with treatment, there is markedly improved survival, as you can see here on the left-hand side of the slide. These are survival curves by when you were born. So if you were born in the early 60s, your survival was worse. It got a little bit better in the late 60s, got better in the early 70s, still better in the late 70s, and then better and better in the 80s and 90s. And we expect that now, somebody who's born now, if they're well transfused, well chelated, they should have near normal life expectancies. So despite all of these improvements in the safety of the blood supply, we don't have to worry so much now about infections, a reduced rate of developing antibodies because of better cross-matching, the ability to use an oral iron chelator as opposed to an injection, improved monitoring of iron overload to tailor therapy individualized, improved treatment of hepatitis for patients who got hepatitis, and improved outcomes to stem cell transplantation. All of these have made huge advances, but there still remains some unmet needs. We don't have a way of really targeting that ineffective erythropoiesis short of doing a transplant. What we do now, so we do now have luspatercept, which is a maturational agent, which can ameliorate ineffective erythropoiesis, but it doesn't work for everybody, so that's still an unmet need. If you can reduce ineffective erythropoiesis, you can reduce the iron loading from the intestine as well. So particularly important for non-transfusion dependent patients because that's the source of their iron overload. We don't really have good ways of preventing the iron overload. As I mentioned before, you can't really take the iron out of the transfusion before you give it. So it's going to have to go in, and then you have to worry about getting it out. Ways of reducing bone disease are a little bit more challenging, improving overall quality of life, and curative options for those individuals who don't have matched sibling donors. And this is where gene therapy might come into play. And so we'll spend the next few minutes talking about novel therapies. And again, I won't go into great detail because I do want to leave some time at the end for questions and answers. So different approaches. So as I mentioned, there is an impairment of this balance of alpha and beta globin. You're not making enough beta globin in beta thalassemia, you're not making enough alpha globin in alpha thalassemia. And so if you could do something to the genes to make them make that globin better, then you can correct this defect, and that will correct the pathophysiology of the disease as a whole. And potentially this is a curative therapy. So stem cell transplant is a curative therapy, but gene therapy and hemoglobin induction by either gene therapy or by medications may also ameliorate this impaired, this abnormal ratio between alpha and beta globin production. Ineffective erythropoiesis may be targeted. And so luspatercept already did that, and that is now approved for use in the United States. But there are a couple of other agents that are also in clinical trials that I'll mention as well. And then you can address the iron side of things by the use of these things called mini hepcidins. Hepcidin is a hormone in your body that regulates iron. And you can modify the hepcidin and therefore reduce the risk of developing iron overload in the heart or in the endocrine organs. And so those are strategies that have been used as well, which I'll mention a little bit of as well. So this is luspatercept, and I'm not going to go through the slide. Basically, what you're doing is you have the accumulation of some intermediate proteins when you have ineffective erythropoiesis. Those proteins prevent normal maturation from occurring. If you remove those proteins, which is what luspatercept does, it's a trap. It traps those proteins and removes them. That will allow the maturation to progress more normally, and you'll be able to produce now more red blood cells than you'd produced before. And essentially, that would reduce the amount of transfusion you'd need for transfusion-dependent patients, and it'll improve the degree of anemia in non-transfusion-dependent patients. So your hemoglobin level will go up because you're now having more maturation, more red cells coming out of the bone marrow. So I won't go through this schematic as well, but this was the BELIEVE trial for luspatercept. This was the phase 3 trial that was done comparing luspatercept to placebo. And essentially the goal was to see whether luspatercept, given over a period of 48 weeks, so almost a year, whether it could reduce the amount of transfusions required by transfusion-dependent patients. And sure enough, what they were able to show was that it did. In the primary endpoint time period, which is 13 to 24 weeks after starting luspatercept, 21% of patients who got luspatercept had a reduction by 1/3, 33%, of their transfusion requirement compared with placebo. If you looked at other time periods or any 12-week or 24-week period, you did have statistically significant reduction in transfusion burden with luspatercept compared with the placebo arm. And then there were some patients who even had a 50% reduction from baseline, and that all of those analyses also showed statistical significance. So luspatercept could reduce transfusion requirement in a certain subset of patients with beta thalassemia. And as a result of that, it was approved by the FDA in 2019 and the EMA in Europe in 2020. The side effect profile is pretty good. You're able to tolerate this fairly well, even though it's an injection, but it's given once every 3 weeks. The main side effects, the most common side effects, were bone pain or joint pain and some dizziness. It is also effective in patients with different types of genotypes. So whether you have beta 0 or E beta 0 or E beta plus, it could be effective in you as well. And there was a report last year which looked at quality of life markers and showed that patients who responded to luspatercept, in the responders, there was an improvement in quality of life as well. There are some additional trials that are underway. There's luspatercept versus placebo in non-transfusion-dependent patients. This is called a BEYOND trial. And then you have luspatercept in transfusion-dependent pediatric patients, which is ongoing as well. This is one of the other drugs, mitapivat, which activates an enzyme called pyruvate kinase, which is an enzyme in your red blood cell. And what that does, what the drug does, is it improves the functioning of pyruvate kinase, allows you to make more energy, or ATP, reduces the oxidative damage that occurs to the developing precursors in your bone marrow, allowing them to survive, allowing them to mature better, and allowing them to produce more red blood cells. So this was tried in individuals with alpha thalassemia and beta thalassemia. This is one of the only trials that included both alpha and beta thalassemia. And these individuals were given an initial loading dose for 6 weeks and then a higher dose for 18 weeks. And there were 13 patients in all, 4 with alpha thalassemia, 9 with beta thalassemia. And in both groups, there was an increase in hemoglobin level at a median time to response of about 3 weeks or so. Individuals with alpha thalassemia had a 1 gram, 1.17, almost 1.1 and a fifth gram increase in hemoglobin. And individuals with beta thalassemia had almost a 1.5 gram increase in their hemoglobin. These are all non-transfusion dependent patients. So what's happening now is that this drug is now in clinical trials, or about to start clinical trials, in patients with alpha and beta thalassemia, but both transfusion dependent as well as non-transfusion dependent, to see whether or not these results from the phase 2, the early trial, do translate when it's given over a longer period of time to a larger number of patients. There are other drugs called mini hepcidins or hepcidin mimetics, which I will not go into details because one of the drugs did not meet its endpoint. The trial was abandoned. And the other one, we don't really have any recent data from either. But you can try and ameliorate the ineffective erythropoiesis, the ineffective red cell production of bone marrow, by modifying the iron in that environment by using this drug. So more to come down the road, but right now we don't really have that much data in humans on this. So we'll spend the next 5 or 10 minutes talking about gene therapy, because this is very exciting as well, and I'm sure all of you have been waiting to read and hear more about it as well. There's 2 approaches. One is to add a gene. So if you have beta thalassemia and you're not able to make normal amounts of beta, you can add a beta globin gene. And that will allow your stem cells to now produce enough beta globin. Or you can add a gamma globin gene, which allows you to make more fetal hemoglobin. And so it bypasses the need for having beta globin by producing more gamma globin. Gene editing can be done as well, and you can either allow or promote more fetal hemoglobin production by removing the repression or suppression of that production by affecting a gene called BCL11A, or you could use gene editing to correct the beta globin mutation itself. And remember, editing just means going in there, clipping, making some modifications, whereas addition is just putting in a new gene. Okay. So the way in which this is done is that stem cells are collected from the patient. They're harvested either from peripheral stem cell collections, or some folks will do bone marrow harvesting. The stem cells are purified and then sent to the laboratory, where they're treated, and either the gene is added or the gene is edited. And then they are given back to the patient after the patient has received chemotherapy to ablate or to kill off their own bone marrow. So basically, just like in a transplant that you'd be getting from a brother or sister, where you get chemotherapy to make space in the bone marrow, to kill off your own bone marrow, to make space and allow your siblings' bone marrow now to engraft and take root in that bone marrow and start making normal cells. That's why you need the chemotherapy. So that has to be given, and then you get your own cells, but they've been modified. You get them back, and then they go in and graft, and they go in and set up shop in the bone marrow and start producing red blood cells. And then as they start to produce red blood cells, now you're producing them more normally, and therefore your transfusion requirement goes down until eventually you may be able to stop transfusions altogether. So there's several trials. There's lentiglobin, which is the company that makes this called Bluebird Bio. And then there are gene, which is one of the addition mechanisms. And then there's another one in Europe that we don't have so much data from. And then there are a couple of trials of gene editing. The one that has the most data is the one that I'll discuss in more detail, which is the CRISPR-Cas9 gene editing done using the product called CTX001. So these are some of the early results from lentiglobin for the Bluebird product. And you can see that patients with both the most severe genotype, beta 0, beta 0, as well as the less severe genotype, the non-beta 0, beta 0, did have a response and did become transfusion independent. And those that did not become transfusion independent at least had a marked reduction in their transfusion requirement. So the blue bars are your original transfusion requirement and the gray bars are after you got gene therapy. So most of these patients respond except maybe one or two that didn't have as much of a response in terms of reducing the transfusion requirement. Subsequent trials, after they modified their manufacturing process for the cells, showed even better results. And you can see here that patients with beta 0, beta 0, which is here at the bottom, and non-beta 0, beta 0 had much better results with higher hemoglobin levels as well and achieving transfusion independence for the most part. So essentially, and these are the pediatric patient trials, which also showed very good results. You can see all of these patients who were greater than 12 years old did become transfusion independent. And all but 2 patients less than 12 years old also were able to become transfusion independent. And so this is essentially a possible way in which you can completely get rid of the transfusion requirement of these individuals and essentially, quote unquote, cure them, not unlike getting bone marrow from a relative, except that this is your own bone marrow, which has been modified genetically in the laboratory. So that was the addition approach. This is what you do in the editing approach. Okay? You can disrupt a gene which is causing suppression of gamma globin expression and allow more gamma globin expression to produce more fetal hemoglobin. So instead of producing hemoglobin A, you produce hemoglobin F, but your hemoglobin becomes more normal and you're not as anemic. The way in which this is delivered is the same. You have to do the same thing. You remove the stem cells, send them to the lab. They do this editing, but it's important to keep in mind that where gene addition requires the presence of a vector, which is usually a virus, a lentivirus, that carries that gene and then inserts it into the stem cell. Here you don't need any viruses. And this is just done by editing using this technique called CRISPR-Cas9. That then can cleave out that gene and can even correct the gene if you want to do that. And these are the results from the CRISPR trial, CTX001, and they have results in 7 patients that have been published so far. And you can see that 5 patients became transfusion independent at 6 months. That's the endpoint. The other 2 showed that they were moving towards transfusion independence, but they hadn't reached the 6-month mark yet. So you can't say that all 7 patients responded, but it seems like maybe all 7 patients will respond. And this just shows that one of the patients has been followed for over a year and a half, has a hemoglobin of 14, and essentially seems to be doing really well without any transfusions at all. So to summarize about gene therapy, gene addition trials as well as editing trials have achieved transfusion independence or quote unquote a cure in these individuals, especially so with patients with less severe genotypes like beta plus, beta plus. In none of the trials, whether gene editing or gene addition, none of the trials have had any deaths. And most of the side effects or toxicities have been what would be expected in individuals who got myeloablative condition, who got that chemotherapy essentially. Okay. But again, some of these trials are early. We have about 5 years worth of data on the Bluebird trials and only about 2 years worth of data on the CRISPR-Cas9. So we'll have to wait and see, with more time, whether they're durable, whether there are any other side effects that come up or not. The FDA has required 15 years of follow-up for all these individuals in these clinical trials. It's also going to be expensive, most likely, and so availability will have to be addressed as well. In the last 2 minutes or so, we'll talk about this transition from pediatrics to adults. It is really important to keep this in mind. It's very important that this happens well, because essentially it's a difficult time in these patients' lives. It's a time when there are substantial changes that are occurring, both physical, psychosocial. There's related to freedom and independence, supervision, taking your medications or not, a lot of peer pressure to do things like smoke and do drugs and stuff like that. Patients and it creeps up, and patients and families may not be prepared, and all of a sudden the child who is no longer a child and has turned 21 and has to go to a different provider. There may also be some parental anxiety about letting go, finding a new provider team that you have now built a new rapport with. And there's also the challenge sometimes that internists, some of the adult doctors, are not really used to dealing with young adults with chronic illness. They're used to dealing with young adults, but not with chronic illness so much. And so there may be different expectations, and there may be some changes in the healthcare paradigm and stuff like that. So these are things that could result in problems during that time. Some of the issues specific to thalassemia, we know that a lot of the thalassemia centers are in children's hospitals, and the adult hospital is some distance away from the children's hospital. So that's sometimes a big challenge to have to go to a different hospital in a different place. Compliance is a big issue, and we talked about how important compliance with chelation therapy is, and so we were all kind of not that compliant when we were teenagers, right? So it is definitely something to keep in mind, that these individuals, as they get 18, 16, 18, 20, the compliance may not be as great as they're saying it is. Delayed growth in puberty may be an issue in this transition. Chronic psychological issues may play a role, and it is the loss of a very stable relationship that most patients have with their pediatric hematologist. Sometimes they're graduating and going away, so they're going to college, and so all of their support systems, their parents, their siblings, their friends, may not suddenly be there as a result of that. There are also new subspecialists, new cardiologists, new endocrinologists, other providers. And then luspatercept, which is available only for adults in this country, may also be a touching point for this transition. So what I would recommend is starting that process early, assessing readiness for transition with the patient, both the patient and the parent. Provide more time to learn about the disease, to learn about what it takes to manage it, both for the child and the adult. Empower the child, or now young adult, over time to make educated decisions and take charge of his or her own care. Allowing some overlap between the pediatric provider and the adult provider is also ideal. And most importantly, keep channels of communication open. The parents, the patient, the pediatric provider, the adult provider, support staff, nurses, social workers, everybody should keep the lines of communication open. I think that's the last slide. And so all I'm going to do is summarize now. We know that beta thalassemia is a chronic condition with significant morbidity and impact on quality of life. We have improved our care of thalassemia patients significantly. One of the most important things has been monitoring and appropriately treating iron overload. Outcomes for stem cell therapy are better. We've talked about some targeted therapies like luspatercept and pyruvate kinase activators that have great potential to alter the natural history of the disease and improve quality of life. And then gene therapy, which is a therapy with curative intent, is on the horizon, and so far the results have been quite good. So I think I'm going to stop there and see if there are questions, and maybe John, if you have been following the questions in the chat, you can let me know what they are.
Absolutely. So thank you so much, Dr. Sheth. And we did receive, there are a handful of questions listed in the Q&A box. I don't know if you can see that at the moment. It may be helpful for you if you can click on those. And
yes, I can. So the first question, I'll just read through them. The first question is my opinion on thalidomide and erythropoietin in transfusion-dependent patients and non-transfusion-dependent patients. So I don't think that we have good data yet. I know that there are some trials in India that are looking at thalidomide. Erythropoietin is always a challenging agent to use in this situation because, as I showed you before, these individuals already have high erythropoietin levels, already have a lot of proliferation and expansion of the bone marrow, and giving more EPO does not help the situation unless you can make those cells mature. And there is potential for thalidomide to do that. But again, it's really going to be a question of doing the clinical trials and showing that it actually does happen. The second question is where should the hemoglobin be maintained in non-transfusion dependent patients? And that's a very individual question. I don't think you want to maintain it with transfusions, but you want to maintain it at a level where you're not having complications, as in you're not having a lot of vascular disease, you're not developing leg ulcers. And so that's a very individual thing in terms of your quality of life, in terms of your, what you do exercise-wise and stuff like that. All of that is very individual. So it's not something that should necessarily be a one-size-fits-all. Just for transfusion dependence, we do have a one-size-fits-all. As I said, we should maintain 9.5 to 10.5. But for non-transfusion dependent patients, we don't have a number like that. The third question is, can you expand on what exactly is beta 0? So beta 0 means that you have no expression at all of that gene. It is completely mutated. You don't produce any beta globin at all. That is the most severe kind of mutation you would have. And therefore, if you had both beta 0 mutations, you produce no beta at all. And therefore, your hemoglobin is much lower and you have more severe anemia. If you have beta plus, it means that you do have some expression of the beta globin, and that will result in some production of hemoglobin A. And therefore, your anemia is not as severe. When you inherit beta 0 along with E, essentially only have one functioning beta globin gene, which is mutated now to produce hemoglobin E, and the other one is beta 0, so it's producing no beta at all. And so essentially, you have something like an EE condition where most of your hemoglobin is hemoglobin E, but you're also severely anemic because the other beta is not working at all. And so here you have complications. And so these are individuals who could be non-transfusion dependent or who could become transfusion dependent over time. Oftentimes they're not transfusion dependent right away in infancy, but later on in life, they do tend to become more reliant on transfusion, especially the E beta 0 individuals. E beta plus individuals may not be as severely affected. The next question is, does hydroxyurea cause leg ulcers? No, hydroxyurea does not cause leg ulcers. We don't even, hydroxyurea may cause some pigmentation sometimes, but not actual ulceration. There's also no evidence that shows that hydroxyurea particularly benefits or consistently benefits individuals who have already developed a leg ulcer there as well. So that, I think, is the, well, there are other questions in there, sorry. Do you have to get luspatercept injected in the hospital? Yes, it is not going to be available to be given at home because you have to monitor the hemoglobin level before you give the dose, for sure. The next question is, luspatercept is granted access since 2019 in the US. What kind of issues have been noted? My experience has been that individuals have had the same sorts of side effects: dizziness, bone pain, joint pain. I have a substantial proportion of patients who are responding, pretty much similar to what was shown in the clinical trial. So it is something to consider in individuals who are transfusion dependent right now. And then when you have more data from the non-transfusion dependent studies, you'll be able to do that in those individuals as well. Do I think the Bluebird product will resume trials and get FDA approval? I am optimistic about it, but I don't know for sure. Some patients treated with Reblozyl maintain apparently high hemoglobin levels for a while, but they nevertheless feel fatigued. Yes, this is yes. Could some of the red cells produced with Reblozyl not be fully functional? Yes, it is a possibility. And no exercise capacity has not been studied in these individuals. They've looked at overall quality of life. They have looked at physical functioning as well, but not specifically exercise capacity. The next question is, I believe there's a patient on the Bluebird trial that developed cancer. This is not in the thalassemia population. This is in the sickle cell population, totally different underlying disease. No patient in the thalassemia population has developed cancer in the Bluebird trial at all. It does not seem to be related to the gene therapy, but the further investigation is still ongoing, and so we don't have all of the details as of yet. Do you have any advice about low ceruloplasmin levels and lower copper levels in relation to successful chelation therapy? Sometimes individuals who are over-chelated may have low levels of copper. So you do need to make sure that you're not getting over-chelated. Usually, if you're getting chelation, the chelators have a much higher affinity to bind to iron, and so they don't tend to bind to the other metals in your body, like copper and zinc. But if you don't have that much iron there, then the chelator will bind to other metals like copper and zinc. So you have to be careful not to over-chelate. But otherwise, no, you should not have low levels of copper, which is if you're just getting regularly chelated, and you have an appropriate balance between your chelation and iron levels. The next question is, what is the safety concern for thalidomide? I don't think I have a safety concern so much as an efficacy concern. And I think a rigorous clinical trial will address both the safety issues as well as the efficacy issues. And so I think we really need to do that before recommending thalidomide for these individuals. Yes, deferocyrox has kidney and liver function abnormalities. I already talked about that. Is there any drug available to reduce the spleen size in transfusion-dependent patients? No, not specifically, but it's possible that luspatercept might reduce the size of the spleen as well. And I think we've already talked about my opinion on splenectomy, which is to do it when it is specifically indicated for somebody who has a very large spleen or who's not able to keep up with their iron chelation therapy because they're getting so much blood and not able to tolerate higher doses of iron chelator. So in that situation, I would take it out as well. Are you still recommending stem cell transplants? If you have a mad sibling donor, yes, I am still recommending stem cell transplants. For the others, I think if you don't have a mad sibling donor, then I would recommend waiting for gene therapy right now. What is the best hemoglobin level to get Reblozyl at? I don't think there is a best level. I think the issue is to get it at a regular interval to be able to reduce the hemoglobin, to reduce the transfusion requirement. So you really have to look at the transfusion requirement or the side effect profile to decide whether it's working or not. The next question is, no changes in hemoglobin and no side effects. If you don't have improvement in your transfusion requirements, then I would suggest that after 3 doses to increase the dose of the Reblozyl, see if that works. Give it 2 doses to see if that works or not. If that doesn't work, then I would stop it. And then I think one last question, how long do you think it will be before gene editing and gene therapy would be in reality? I cannot answer that question with any level of confidence. I'm hopeful that maybe in the next year or 2 that the FDA will actually approve gene therapy as well. But again, I don't know that for sure. I think those were all the questions. Did I miss any, John?
I think we got them all. Thank you so much.
All right.
Okay, and that takes us past the hour. So Dr. Sheth, I just wanted to thank you so much for a great presentation. We truly appreciate your time and expertise. And thank you so much, everyone, for joining. I hope this was beneficial for you. You will be receiving an evaluation form via email. If you could please take a second to complete that after the program when that comes in, we would greatly appreciate your feedback. So again, thank you so much, everyone, and I hope you have a great rest of the day.
I'm just going to add one last thing. if you're not part of the Thalassemia Foundation, please really consider becoming a part of the Thalassemia Foundation. And if you are, and if you have additional questions, please submit them to the Thalassemia Foundation, and they will get them to me or to somebody else to get answers for you as well. Okay.
Great.
Thank you all
Okay.
very much, and I wish you all the best.